Hello, my name is Till Lersch from the Department of Radiology of the Inselspital, Bern, Switzerland. I will talk about posterior extraarticular ischiofemoral impingement. I have no conflict of interest. Femoral acetabular impingement was described in 2003. CAM and pincer type deformities were described. On the right top we see a patient with CAM type, FAE and associated cartilage damage. On the right below we see cartilage damage associated with pincer FAE, but what about femoral version? This is a patient with increased femoral version on both hip joints. They often have a posterior impingement test that is shown here. And these patients often have an in-toeing gait as shown on the right side with the feet pointing inwards. And we asked what is the range of motion, what is the prevalence of posterior extraarticular hip impingement, and does the location of the posterior impingement zones differ between hips with increased femoral version and the control group. It was a retrospective comparative study including 52 hips. They all had increased femoral version above 35 degrees and the positive posterior impingement test. This is the protocol of the pelvic CT scan. These 52 hips had an increased femoral version of 35 degrees and were mainly female patients with a mean age of 30 years. We compared it to a control group of 20 hips with normal femoral version and normal acetabular version. The measurement of femoral version is shown on the right side. We performed segmentation of pelvic CT scan and used the 3D models for bony collision detection and used the equidistant method for range of motion and impingement simulation. Posterior impingement test and the Faber test were simulated. Statistical analysis was performed as shown here. These are the results for the range of motion. We found that hips with increased femoral version had a decreased external rotation and decreased extension compared to the control group. Posterior impingement was located mostly extraarticular during the posterior impingement test and during the Faber test. We found that impingement was mainly located between the lesser trochanter during the posterior impingement test, and during the Faber test we found that the greater trochanter and the ischial tuberosity were involved during the impingement conflict. The results for location of impingement are shown here. In the middle we see that hips with high femoral version had the impingement conflict between the ischial tuberosity and the lesser trochanter as shown by the red circle. In contrast here, during the Faber test, we see that the hips with high femoral version had the impingement conflict on the intertrochanteric area and the greater trochanter. These are the results shown for the location of impingement. We see that hips with high femoral version had a significantly increased prevalence of extraarticular impingement on the intertrochanteric area and on the lesser trochanter. And this is shown for the Faber test. These are the limitations of this study. We use only bony range of motion without soft tissue. This is the summary of the study. We found that hips with increased femoral version had decreased extension and external rotation, and the results were published in the Orthopedic Journal of Sports Medicine. We found that posterior hip impingement can be caused by the lesser and the greater trochanter, and we recommend that femoral version should be measured in all symptomatic patients to detect increased femoral version. So thank you for your attention. You can find the videos of the impingement simulation online in the supplementary material of the publication. Thank you for your attention.